Well, thank you very much for inviting me to come speak. I think that the elderly population is a very unique population. They constitute the majority of patients diagnosed with AML in this country, and there are a lot of clinical challenges. You know, when you see a 70, 80-year-old person with this diagnosis, things that come up immediately is, are they functional? Are they able to accept chemotherapy? You know, one of the big questions that goes on in selecting therapies or clinical trials for this particular age group is, are they quote-unquote fit, or are they quote-unquote unfit to receive intensive chemotherapy, meaning chemotherapy that's going to require them to be in the hospital for 4 or 5 weeks to get cytarabine and anthracycline-based therapies, or should we be really thinking more about outpatient therapy, hypomethylating agents, low-dose cytarabine, experimental agents? You know, is that something that's going to be more realistic given the comorbidities of these people? Some of them have elderly family members. Some of them, frankly, don't have that much support. You know, if somebody that has a lot of support at home, a lot of dedicated family members, or somebody living in a nursing home, that type of thing. So those are the things that we really consider. There's data that was presented at this ASH meeting by Mohammed Sawar and colleagues and consortium, looking at how older patients function using comorbidity index to better predict how patients would do with either intensive or non-intensive therapies. And his data suggested actually across the board that outcome-wise, even though these patients have comorbidities, that they will do better with an intensive chemotherapy. However, that has to be layered upon the individual patient and their preferences, etc. So there are a lot of things, a lot of complexities with this particular patient population.